Hello and welcome to this virtual session on virtual care hosted by Edmonton Health City. My name is Mack Male. I'm the co-founder of Taproot Publishing. We're building the future of local news right here in Edmonton, Alberta. And I'm thrilled to be hosting this conversation, and I want to thank Health City for bringing us all together. So we're going to get into what is virtual care and what is the opportunity, what are some of the challenges in rolling this out across the country. And to help us explore that, we've got four very experienced folks here through the power of the internet who are going to help us speak to that. So I'm just going to quickly introduce them, and then we're going to dive right into the conversation. So first up is Christy Prada. She's the Vice President of Business Development at Maple, which is a virtual care provider, building a connected healthcare experience to power the future of healthcare. So she's going to bring some experience around what does a provider of virtual healthcare actually think about how this is rolling out. Sarah Draper is the Senior Director of Healthcare Strategy and Complex Care at Shoppers Drug Mart. Shoppers recently launched a virtual care service for patients in partnership with Maple, so I think they're going to have some really interesting insights to share. Rohit Joshi is the CEO of Brightsquid, which is Canada's leading compliant communications services provider for the healthcare industry. So he's going to bring a slightly different perspective to virtual care, which I think is really important. And last but not least, we've got Chris Carvalho, who is a digital health expert and Health City consultant with a long career in the private sector, providing consulting services to public and private sector clients in the health system. Welcome, everyone.
Thanks.
Hi, Mac.
All right, so we're gonna have a conversation here. My job is to keep us on track, guide us through that a little bit, prompt you with some questions, but feel free to jump in. This is the new normal, so let's keep it natural. Chris, I wanna start with you. I'm interested to know what is a good definition of virtual care from your point of view? What is it not? And maybe as the representative of Health City here, what is Edmonton Health City's interest in hosting this discussion this morning?
For sure. Yeah, so I think at its basic form, virtual care is the delivery of healthcare services through virtual means, whether that's telephone, secure messaging, video, sort of a number of different mediums. And certainly we'll look to the others to explain, a bit more in detail on each of those. But it is changing, I think, quite a bit. Just given the current circumstance, there's more interest, there's more awareness about it, and the process of implementing has been accelerated. And I think the reason that Health City is interested in hosting a discussion like this is to make sure that we can help share some education around the best ways to start looking at virtual care. There's a number of different ideas around, what works and what doesn't. And I think, even though we're accelerating the delivery and the implementation, we want to make sure that, folks that are tuning in are educated so that we're not making, mistakes because we're under time pressures to implement, but that we're thinking through some of those longer term objectives and how we can truly roll this out. So that's why we were excited to get, experts from across the country to share their thoughts and some of their experiences on what they've done in their current organizations and with some of their partners.
Great. Okay, so Christy, you're a provider, or Maple, where you're from, is a provider of virtual care. So help us understand a little bit more for the layperson. What we've had telemedicine, right, in the past. How is what we're talking about different from going to a physical site where they've maybe got a really complicated video conferencing setup? All of us are just using laptops or devices, right? So that's an example of sort of the democratization of the tech, but maybe we can get your perspective.
Yeah, thanks, Mac. So I would say, historically telemedicine has been, something that existed in Canada for a long time. And as you've noted, predominantly through still some physical infrastructure, right? Patients having to travel to either visit a video platform for visits facilitated by a nurse or somebody in person. That was the predominant way that telemedicine was done in the past, in addition to, seeing examples of it through, provincial hotlines where people could call in and speak to someone directly over the phone. That's the kind of more historical definition of telemedicine. Now in this day and age, with the advancement of technology, and mobile devices and quality of screen and camera and internet capability, virtual care it's really similar to telemedicine. It's just a broader definition where you can interact with a physician or a provider online using more than just phone. You can do it via video, you can do it via instant message and text, as well as, sharing of patient records. So we consider virtual care to be, the interactions between patients and providers via video, text, you know, or phone, as well as exchanging of healthcare information and data through a you know, a platform-based solution. The Maple platform is available on both web and on mobile, so you can download the app on an iOS or an Android device. So as you noted, you know, the average person who has a computer or a smartphone is able to now access virtual healthcare, which is, I would say, one of the newer kind of evolutions in the last, you know, 5 or so years. This is something that's relatively new in Canada. But interestingly enough, it's not new in the rest of the world. So virtual care has been actually in place for quite some time. If we look at our neighbors to the States, Kaiser Permanente is one of the biggest health systems in the US, and they've been using virtual care and a variety of virtual tools to shift more of their care interactions into the community, you know, keeping patients in their home and, you know, leveraging digital technologies to streamline and make things more efficient. We also know that in Europe, specifically the UK, also in parts of Europe as well, there's been a lot of history of telemedicine and virtual care. You know, more what we're seeing here today has been in place there for quite some time. So Canada is a little bit of a laggard in terms of adopting this type of technology, but we are seeing, you know, in the last 4 to 5 years, an increase in you know, this coming to play in Canada.
And would you say there's a shift in the type of service? So telemedicine, if I understand correctly, was often used to connect people who are in remote locations to specialists, things like that. Whereas virtual care, we're seeing that used more and more for a normal, regular interaction between a patient and a doctor. Is that a fair thing to say?
Yeah, absolutely. I would say, you know, historically it was more of a, you know, way to kind of connect in remote areas that lacked the resources or, you know, local support to actually have those specialists or caregivers in the community. Now we are seeing that kind of, you know, almost commercialization of it, or consumerization of it is maybe the more appropriate term, whereby patients are actually empowered to take control of this into their own hands. They're able to go on their mobile device and speak directly to a primary care provider. So not just for specialist care, but for a broader set of needs, you know, everything from cough, cold, flu, you know, simple infections, really, you know, a lot of the primary healthcare concerns that are more acute in nature that you could see your family doctor for can be done online. And that is something that we're seeing, you know, more and more of. And I think that is kind of growing or creating to the growth of the popularity of this in this day and age.
Okay, great. So Rohit, well, how does secure messaging fit into this? How does what Brightsquid does fit into virtual care?
Sure. So we've really focused on, I would call it the virtual front desk, recognizing that, you know, the end result might be a phone call or a video call or an in-person visit. We're looking at this really from a patient perspective and trying to provide the product that will allow a triage of all of the incoming requests. You know, one of the things that we're recognizing, particularly in this time of extreme pressure on the health system, is that many of the interactions are still just the normal interactions that people had before the pressure was put on. So people still need to get prescriptions. People still need to get their lab tests for whatever reason. And so those are types of requisitions that don't rely on video and don't rely on even a phone call. Many of those are chronic conditions that can be managed. And so we've seen a tremendous increase in the amount of regular communications that are occurring that actually figure out whether or not it even needs to be escalated into a video or a phone or what have you.
Yeah, that makes a lot of sense. I mean, we do so much of our day-to-day lives through messaging anyway.
Yeah. And there's a reason, there's a reason asynchronous communication like that, where I can just push something out there and when I hear back, I get the answer. You know, if we're really trying to lessen the burden, it's not going to happen through a one-to-one interaction with a provider. We actually have to change the system and how people are requesting services and also how those services are being delivered.
Right. Sarah, I'm going to come to you in just a second on the partnership that you have with Maple, but first I just want to go back to Christy quickly. So I looked up some statistics prior to this, and so I see that in Canada, we've got about a 90% penetration, market penetration for internet access. More than 80% of Canadians own a smartphone. And according to the CRTC's plans, 90% of Canadian homes should have access to download speeds of at least 50 megabits per second by the end of 2021. So it feels like we've got a lot of the technology, the solid foundation of technology in place to allow things like virtual care to thrive. So Christy, you were mentioning that we're quite behind the curve in Canada compared to other places. Why do you think that is, given that we've got you know, pretty impressive market penetration of these basic technologies compared to some other countries?
Thanks. I think there's a few factors that contribute to this. First being, Canada is, a relatively complex health system, right? We're not a national health system. We're made up of, many health systems within a country. So in order to kind of, be able to take advantage of a technology like this, or for a technology player to come to Canada, there needs to be a really intimate understanding of the legislation rules around physician practice, around how that works across jurisdictions, and then also how billing and reimbursement works and how that fits in with funding and fee codes. So there's a lot of nuance to being able to function in this type of an environment. And I think historically, there just hasn't been, the resources or drive of some of these international companies who have built out solutions to really dedicate resource effort to figuring out, the many different mini provinces that we have here in Canada and navigate the system. So I think it took, that local level of innovation to say, okay, we're going to bring our local healthcare expertise and navigate the system and build something that works for the Canadian context. I think it just took a bit more time for that to get here for that reason, because of the complexity. And also, in the nature of our system, one of the best things about it is that we are a publicly funded system, but with that creates a lot of complexity when you're a private company looking to launch services. So messaging has to be managed very carefully. There's a lot of education and engagement required for physicians, for governments, for Canadians as well, to really understand how this fits into the system. So, all that to say, I think we've seen a lot of traction in recent years. And, I think with the growth of the internet and kind of people being engaged online, it creates a forum for people to engage on these topics and educate themselves. But it also, is one of the things that has made it challenging to kind of grow an offering in this space. I do think, though, that in the last, few years, I've been with the company for close to 3 years now, and I've seen a huge shift in the Canadian landscape, not just because of what we're seeing right now, with the COVID situation, but more broadly than that, in the last 5 to 6 months, the conversations we've been having with public sector, with companies, with corporate partners, with hospitals, with systems, and even with Canadians have changed drastically from, who are you and why are you trying to do this, to, I've heard of virtual care. This is something I've been thinking of for my employees, or, I'm a hospital and I've been thinking about how to integrate digital technologies into my care delivery. The conversations are really shifting.
Okay. Yeah, it seems like the demand is there, right? So I was looking up some information from the Canadian Medical Association. This is from a couple of years ago now, but at the time they said there was 7 in 10 Canadians that said they would take advantage of virtual visits, but less than 1 in 10 had actually had that experience of a virtual visit. And I would definitely put myself in that bucket. Like, I'm all in on this. I think I use my phone for everything. I was complaining that I can't use my phone for the bus. Why can't I use it to talk to a doctor as well? So Sarah, I know that the partnership you guys did was kind of more about increasing accessibility, but I'm interested in your thoughts on how important it is you think that Canadians have this opportunity to have that virtual care experience in helping to roll this out further.
And I mean, the reason why we were able to partner with Maple and move so quickly in the current context is that we actually have been working with them for quite a while. So we were working on a project in the West Coast where virtual care is a little more kind of prevalent and used by the community to put virtual care in our stores. So that when you come in for an in-store diagnostic, you're able to kind of have almost a mini walk-in clinic. So, you could walk in, you can do a point of care strep test with a pharmacist. Historically, you would have had to then take that test and go to a walk-in clinic and come back and fill the script. So it's this really disjointed experience. So we were in the process of, we were a couple weeks out from launching actually across the province of British Columbia, that we would input a Maple platform within our stores. That's still going to go live at one point when we all make it through this scenario. So virtual care for us has been kind of a core component of our strategy of increasing access to Canadians. So you'll frequently hear people say, 85% of Canadians are within 10 kilometers of one of our stores. So one of our core platforms is that we are more accessible, more available. It is very convenient. We have long hours, and you can come in and talk to a pharmacist at any time. I think, using the complementary service of virtual care to even more greatly increase that access is highly aligned to our mission and highly important to kind of our overall vision for what healthcare could be in this country. So it made sense historically, pre-COVID for sure, to work with Maple. And then, obviously in the current context, we were able to expand that offering in a national platform in pretty short order to be able to provide access to Canadians so that they can stay home and get access to a physician. And I think, through the long-term vision the feedback we're getting is once people try it once, they're in.
Right.
You realize how convenient, how helpful it is, how fast it is. So I really think, that low, 1 in 10 that have said that they have actually done it, even though 7 in 10 said they would, once you've downloaded the platform, once you've got the tools and you understand the process, I have a feeling that this is going to increase dramatically.
And I would
go ahead, Christy.
Oh, sorry, I was just going to add to that. We're really grateful to the Partnership for Shoppers, because I think when you have, credible thought leaders in the industry who have the breadth, scale, and the brand image and reputation of being, forefront of consumer-facing healthcare, that's been really powerful for us in working together, because we're really leveraging each of our strengths to help, educate and inform people about virtual care and bring it to them and make it more accessible and help to lower the barriers around trying it the first time. To Sarah's point, it's sometimes about trying it to believe that it can work. So that's something that I really see as being a huge value out of this work together that we've been able to do. It's helped to kind of spread that awareness and engagement. And, at the end of this, hopefully more people will have tried it themselves, or at least will have known someone that has tried it. And I think that's how you start to get momentum.
Just out of curiosity, are you guys seeing a certain demographic that is, of that, 1 in 10 or whatever the number was? Is it younger? Is it older? Is it a mix? Just curious on what you're seeing.
Yeah, I can speak to that. We're really seeing a mix. I mean, certainly, you're going to see easy uptake from, the groups that you would expect, right? Millennials, those that are really comfortable with cell phones and have, do their banking and everything else on their phones. They're obvious, early adopters of this technology. But we're also seeing all different types of demographics, right? We're seeing families, people with young children, two working parents who don't have time to, leave work and take, the kids out of daycare to go to the clinic, or who don't want to go to the emergency department in the middle of the night with a screaming child who has, the same eye infection that they always have. We're also seeing people not only in rural areas, but also urban areas who struggle with access, right? Just because you live in a city doesn't mean you have a family doctor, doesn't mean that it's easy for you to, make time out of your day to see a doctor. And then also, the older demographics as well, because, because we've built something that's so simple and easy to use, this kind of lowers the technology barriers around access for the older generation who may have, been intimidated by this type of technology, but through, a partnership with shoppers and then also ease of use, I think that further lowers the barriers around that.
Rohit, you want to jump in there?
Yeah, we tend to see more of a clinic demographic, because we install our product at the clinics, and so what we're seeing is probably what you'd expect, which is the more chronic patients, so 50 plus, are the ones that typically need more attention and have more routine requests. And so our demographic tends to skew a little bit older. I think the oldest person who self-identified themselves as being over 90, and the youngest one has been under 20. So I think, again, to Christy's point, I think all over the map, people are finding that level of convenience. But I would say that ours, for whatever reasons, whether it's the demographic that's been invited to use our product or whatever, we're tending to see about, over 50, over 55 being the predominant group.
Cool. Okay, so Rohit, one of the things I wanted to ask you about was your thoughts on the messaging that we often hear around virtual care, which is that it can reduce the burden on the healthcare system. Yeah. And you mentioned earlier, there are a lot of things that can be done without having to actually speak to a doctor via video. It can be done through messaging and things like that. But these are real doctors at the end of the day on the other end of those devices, right? So aren't we just taking doctors out of that pool of physicians who would normally see patients face to face? Like what is sort of the impact on the healthcare system of virtual care?
Yeah, sure. So, I think that if we separate out sort of an interaction with that a clinician may have with a patient, there's sort of pre-visit, and then there's visit, and then there's post-visit. So if we're trying to look at the broad range of things that may happen, the triage bit is something that we focus quite a lot on, because it doesn't require the same sort of attention, care, and control that an in-person visit would require. And so our typical statistics have shown that a typical consult with a physician will be less than 2 minutes through a secure message. And if we look at that versus a typical 15-minute visit or 10 to 15 minute, could start to see the throughput being dramatically different. if we can handle routine requests like prescription refills and others that we've already talked about. So there's a dramatic efficiency that's going to be gained from that. The other thing that we find secure messaging being very well built for is bulk messaging. So that I, as a physician, could bulk message all those at-risk populations and say, here's what you need to watch for. Here's what you're going to be looking at. And what that does is it should protect the clinic from, I wouldn't say curious, but concerned individuals who don't know exactly what they should be looking for and don't know what to trust online. And so there's a great opportunity in that sort of a distribution of message. And then post the visit, you know, there's always things that have to be written up and new requisitions that have to be sent. All of those can be automated as well. And so I think there's quite a bit of efficiency on either side of the in-person visit. Some of those will result in no visit needed at all. And some of them will require that 15 minutes or 10 minutes that I have with a physician, that it be in person. You know, one of the things that we did was we did a great study with the University of Calgary and some of our clinics, and they asked the population of patients that we have, how would you choose to use secure messaging versus an in-person visit? At that point, they didn't test for video, but I think it's going to be very similar to the video visit, to the in-person visit. And their feeling was that if I want routine test results or routine interactions with the clinic, or if I just want to understand my appointment schedules and where I need to be and when and referrals and so on, all of that was better handled actually by secure messaging, because I didn't have to wait in the waiting room. No one had to wait for me, and no one had to meet with me for a 2-minute, you know, interaction. On the other hand, if I wanted to discuss something that was quite personal, or if I wanted to discuss something that was a major condition of, you know, we're in the middle of one, then I would like to see somebody. And I think that makes perfect sense. That's the way I feel. I can't imagine it being different for many people. And so that's how we think we can add efficiencies, is taking away so much of the interaction that doesn't require an in-person visit, where we can get one clinic to many patient interaction.
Okay, that makes sense.
So Matt, can I just maybe,
jump in, Chris? Yeah.
I think it might be important to sort of differentiate between where we're reducing burden. I think there's sort of two sides to this. I think, as Rohit explained, you know, reducing burden on existing clinics that are using some type of virtual care for their patients. And then I think there's also, you know, the model that Sarah and Christy had talked about as well, that's reducing the burden on the system from like a virtual walk-in perspective. And I think those, you know, given right now, I think it's important to educate on both of those sides, because I think when we say virtual care, no one's quite sure which model we're talking about, and a lot of the different players are getting into both of those worlds. But I think, and maybe I'll look to Christy or Sarah to talk about that. But I think there's a huge opportunity for you know, reduction on burden right now in those kinds of situations, and then I think there's a place for it also longer term.
I think it's particularly acute right now, but I think that's an issue on any day. You know, we do have a constrained resource environment when it comes to healthcare, and I know everyone hears the stories, and certainly I've been a patient where, you know, you're sitting in the emergency room for 6-8 hours, right? And that can be because people don't have anywhere else to go. So if you don't have access to care in an acute environment, or you don't understand where you should be going, and I know Maple has done some really interesting things in Prince Edward Island that maybe Christy can speak to help alleviate that burden on urgent care, emergency room, even walk-in clinics. It could be, it's a huge opportunity, I think, that allows physicians to use up more of their time in a way that's sort of more convenient for them. So both from the provider side and from the patient side, it's kind of a match made in heaven. It really is a unique situation. I think it's more acute right now, but I think it's an issue every day.
Sure.
Christy, do you want to jump in on that?
Yeah, sure. I would echo kind of what everyone said. These are all really great points. You know, the way we think about this too is really it's a matter of capacity allocation and how can we, best tap into the capacity that exists in the system and help to redistribute it to areas of need. So, one good example of this is the one Sarah brought up where we're actually helping to keep a hospital open in Prince Edward Island. So there was a hospital that was on the verge of closing because they did not have enough physicians to locally staff a small rural hospital. So we're using a combination of our technology as well as physicians from other provinces who've been, locum licensed in the province and then into the hospital to treat and provide all the inpatient care. So that's a great example of distributing resources across provinces into the hospital. Our core physician staffing model also does rely on, that additional capacity that physicians have in their day. An average emergency room physician works about 16 or 17 shifts a month. Again, current context put aside. So that means that they actually have, a lot of, I'll say, days off in the month where, they don't necessarily, have clinic hours or, if they wanted to take on extra practice area, they would have to commit to shifts. Maple gives them a way to tap into that capacity and do so in a flexible way, allowing them to unlock some of that additional physician capacity and provide primary care, into the community when they're not practicing in the ER. And that's just one of the many different examples, but the way that physicians, work schedules work, there's actually a ton of physician capacity in the system, and that's really what we're looking to do. I think Rohit's example is great of, how do you optimize time spent in the clinic? And then we're kind of tackling, another piece of this, which is how do you, optimize that existing capacity that exists in the system and trying to help complement and build out, an end-to-end system where we're really efficient with our resources.
Okay, so this raises another question though for me, which is around continuity of care, right? So we're using doctors from a variety of different places. Maybe it's different than the traditional relationship whereas the patient would go in and see the same doctor over a period of time, build up that relationship. They get to know me a little bit. This sort of Uber for seeing my doctor makes it maybe difficult to do that. So I'm sure you all have thoughts on that, but Chris, I maybe want to start with you and get your thoughts on what that means for virtual care, continuity of care. What is the impact there?
Yeah, so I mean, that's probably been the biggest debate. And I know I've talked to Rohit about this a number of times. So looking at it from, the patient perspective, I've used a number of different virtual care platforms. And as someone that maybe sees my doctor once or twice a year, to be honest, continuity of care is not as important to me at this point in time right now. But if I take a look at my son, going to his provider and understanding, from his perspective, that is more important. So I think when we talk about virtual care, it seems like everything's sort of painted with the same brush, that it's for every patient, for every instance. And I think there's lots of different opportunities for us to use virtual care for, more appropriate use. And think about, what are the appropriate use cases for us to start implementing on that perspective. So I would look to the others, in terms of what they're seeing with the groups that they're working with as well.
Yeah, sorry, just to jump in there, I think it's important, it's kind of right care, right time, right context. And that context is also really important. So it could be, I'm a complex patient, I have an immune condition, I take immunosuppressant, polychronic, all that stuff. For the things related to that, continuity of care is important. If I had a UTI and I've been pre-diagnosed and, I know that that's what it is, is it actually core? It's probably important that my doctor at some point, either I tell him, hey, I had another issue, or, I know through Maple, I can choose to send my patient note visit to my physician. That the context there is different. So I think it's right care, right time, right context. And I think what virtual care provides also is that right time thing. Right now, getting an appointment with my GP, even outside of COVID, will take upwards at least a week, I would say. And that's, I'm in a family health team in Ontario in the current context. So I think it's important to recognize it's different use cases.
For sure.
Yeah, and I can add to that as well, because we're, first off, we're huge believers in the role of the family physician, and we believe all patients should have that family physician relationship. But, the reality in Canada is, as Sarah mentioned, most people cannot get in to see their family doctor same day, let alone same week. So that means that primary care concerns, that arise and are more acute in nature, they're either not getting addressed, or you're going to the emergency room or a walk-in clinic where continuity of care is arguably, not at its prime. One of the things we've tried to do is ensure that for every visit on the platform, we're facilitating that continuity of care across providers on the platform. We didn't want to just have something where you can video with one platform and you have a little chat transcript and move on to the next. We built a back-end EMR system that allows the physicians to essentially, in an online environment, function as a shared family practice. Again, similar to the one Sarah mentioned in her community, where with the family health team, you can go in and see any doctor in that team and they're sharing records. This is what we've done virtually. So we wanted to try to foster that continuity of care, and truly continuity of care means consistency in record keeping. There's a misnomer that it has to be the same provider every time. Physicians actually are very comfortable with continuing on with another physician's course of treatment if they have access to good notes. Now, all that being said, again, really supportive of and encourage patients to have that primary care relationship. And the way we try to support that is making sure we're providing continuity of care on the platform and giving patients a way to access and store and share information with providers on the platform, but then also, as Sarah mentioned, share it out with them in the community. So you don't have, these family doctors in the community that are unaware of what's been happening virtually.
Yeah. Okay. So Rohit, I want to come to you, and I'm wondering if you could also speak to then a little bit about the challenges in rolling this technology out, thinking specifically around some of the things that Christy's just mentioned. Need to have notes. They get sent from one place to another, and virtual or digital records. And it was only just last year that I was able to sign up for an Alberta Health account and log into something, and frankly, it was pretty empty when I did log in. You always hear about doctors faxing things. Like, are those things challenges in, rolling out this technology further?
Yeah, massive challenges. And so, we've taken a different view, right? We're very clinic centric. And so what we've done is tried to understand how does our product work directly with the EMRs. So we've got integrations with large EMR systems so that any sort of secure communications finds its way back into that EMR for that purpose. But we've gone a little bit further than that, even in sort of suggesting that if we're looking for continuity of care, then it's important for me to be able to communicate with the physiotherapist and with the optometrist and with the ophthalmologist and with the specialist. And so we've taken the broadest thinking around continuity and said that it belongs not only at that clinician, at that clinic, but also to all of the people that are interacting with the patient. So very much of a patient-centered view of that, and giving patient access to all of that information. And so our biggest challenge is, the fax machine. And it's startling, that technology is still what is the backbone of Canadian healthcare, is communications that occur by sending it. And sadly, there's multiple cases where that communication system has failed tragically, where people have died because faxes didn't get there or went missing or what have you. And so I think the challenge that we're trying to overcome, and I would say that if anything, this crisis has put a strong lens on the fact that patients don't have fax machines, and we can't get through to them on the phone, the clinics. And by the way, the physicians are at home too, trying to deliver care, and they don't have fax machines. And so one of the great advances in trying to move this forward is you almost want the whole network to migrate at one time. Because if I have to send a fax to that guy and a text to this one and a secure message there, it's not a network that's going to thrive. And so we've been working hard at trying to use this as an opportunity really to understand what that new network of communication is going to be for that patient and their provider, but also for that provider and many other providers that are actually working with that patient. And so, unfortunately, the inertia of the fax machine, which has been there forever and it's somewhat reliable, that's been a great challenge to overcome.
Are there standards and things that we can adopt from other places? Like, as the US was, as it was mentioned earlier, is quite a bit further ahead of us on virtual care. Is there things that they've already figured out that we can just make use of?
100%. Unfortunately, the standards that exist in the US are, in my estimation, quite old now. They were started in about 2011. And so there are new standards that we could adopt quite quickly. And, we've sent a couple of million messages through our service now. So it's, well-heeled, standards-based. We exchange messages with other systems and so on. It's just a matter of the political will and the leadership, I think, to say, okay, let's unplug that fax machine. Let's axe the fax as they did in the UK and start to move towards a secure network that's going to allow, communications between patients, providers, and providers with providers.
Okay. We're rapidly coming to the end of our time, but there's one other thing we need to talk about before we move on from some of the challenges, and that's who pays for this. So maybe, Sarah, we could start with you. I'm interested in your thoughts on, as virtual care becomes more common and it rolls out to more of the population, who ultimately pays for that service?
And I think, the current context of COVID-19 actually has highlighted this. So in the partnership with Maple, Shoppers Drug Mart is paying for this. Right. Outside of British Columbia, we are covering it, I think, officially as of last night through April 10th. And then the program will move off as public systems have started to support it. And so, the private enterprise of this, where we decided to go into it, was really a stopgap measure. I think we are really excited to have seen that the public system has stepped up in an emergency context to fund it. I think, now we've got to start looking longer term. And to my view, I think this is a core component of our healthcare system as we look to become more efficient and more cost effective. And deliver more care to more people with the same resources. So I am hopeful that, we will see greater coverage. I also think, and Maple's had great success with an employer-funded model. So, depending on where the environment goes, I think we'll see some different models come out. But I think, we're at a real turning point right now as you start to see some of the feedback that we're getting from patients who are using this. I don't think you can kind of put the genie back in the bottle at this point. It's one of those experiences that, like, the first time you order food and have it delivered to your house, the first time you use get an Uber or a Lyft car, once you've experienced it, it's so convenient, it's so easy, and you understand what it means. I don't think we're going back. So the question will be, is the public government going to continue to fund this, or are they going to say, no, let's go back to the old world and leave it to employer sponsored?
Yeah, maybe just add to, I think, we focus a lot on how we are compensating physicians to provide this service. I think there's lots of work that can be done to figure out, and it goes back to what Rohit was talking about, put the patient at the center. What other providers, have means in place to be able to provide services to patients that are not always GP visits. So I think, nurse practitioners or mental health providers or the list goes on. I think this should also, open up a lot of conversations to how do we start compensating other groups that are capable of providing some service along that patient's continuum of care, which we probably haven't talked enough about. But I think there's huge opportunity to start looking at, not just compensation for physicians, but everyone that's part of that care team.
And Christy, what's your thoughts on that?
I would echo, all of that. So certainly, we've seen a variety of different kind of payment models. As Sarah alluded, we have a huge kind of side of our business where employers are funding this as a healthcare benefit for their employees. We're seeing governments, step up and fund virtual visits for certain types of interactions, certain mediums, and certain, engagements between patients and physicians. Our perspective would be it's important that there's, that there's a good learning out of all of this, and we can work with governments and public sector and employers and other groups to understand what is the right sustainable long-term funding model, because covered visits for everybody and every interaction is something that's going to be drastically unsustainable and unaffordable for governments. So it's about finding the right types of policy frameworks to support sustainability and funding for physicians, for the tech providers, as well as, for community supports. As Chris alluded to, it's really an ecosystem that needs to, be supported here. And I think there's a lot of policy change and different frameworks that need to be, put in place and really understand, how you shift this kind of current environment into something that's sustainable for the system, for Canadians, and understands that, nuanced network of who's paying for which interactions and which ones make sense for patients to pay for versus government versus, employers, insurers, and other, private sector partners who, have a role in keeping employees and Canadians healthy as well.
Rohit, anything you want to add from your perspective on?
Agreed. Echo the conversation, and especially because we sort of see a different side of it, which is we've had a great rise in psychologists that are using our platform over the past number of weeks, and most of those are private, and most of the dentists that use our platform and chiros and so on. And so I think there's an opportunity and maybe an obligation to create the network but then the funding models have to sort of be varied based on, you know, the needs and the ability for the healthcare system to even sustain it.
Yeah. Okay. Well, where I want to end is with a little bit of optimism around where this could all go. And so I'm interested in each of your thoughts on kind of not predicting the future because that's fraught with danger, but where do you hope virtual care is going to go? What do you think we're likely to see in the short term? And I suppose, you know, just any thoughts on what the long-term potential might look like in Canada. And Rohit, we might as well start with you here.
Sure. So I'll go to what Sarah was saying. You know, the first time I ordered an Uber, I thought, boy, this is a little bit weird. And now I can't do without it.
Right.
I think that this will change how care is delivered in Canada. And I'm excited by that. I'm sure that Christy and Sarah can talk about how the increase in terms of activity that they've seen, but we're, you know, through the month of April, we'll add another 600 or 700 more providers and about 500,000 patients onto our service. And once you have that sort of massive change in the system, it's bound to stick because everyone recognizes the value of it once you've tried it. And I think we've seen the momentum shift. And so I'm optimistic in terms of being able to provide our clinicians to be able to provide better care and actually increase the continuity with their different providers. That's my optimism. And I think we're right around the corner from it.
Okay, Sarah?
Yeah, I mean, I think, you know, long-term, the vision, the healthcare of my hopes and dreams is that this is an integrated system. You know, it's a connected healthcare network with, you know, whether, and my data is portable and everyone can see it, and it's about me as a patient, right? So that I can choose how I need to interact with my physician, and we can have that conversation of, hey, let's do this one on the phone. Hey, let's do this one via video chat. Hey, we can just do this via email. Or no, I need you to come in because I need to do whatever extra diagnostics. And you can start seeing there's different companies out there with remote diagnostics as well. So do we start bringing those in and what framework? And so it starts to becoming this kind of integrated patient-centric view where patients get to choose and work with their providers on the appropriate modality for their own care. You know, as a patient, I would appreciate that. You know, I always think it's silly when it's like, hey, we're going to get your prescription to the pharmacy via fax. Right? Like, you can't say it with a straight face. So I'm looking forward to that future. And again, I think the current pandemic has put us in a bit of a pressure cooker, but this was happening. This was going to happen. Totally. It's just made it potentially a little more acute for the time being.
Okay, and Christy, I imagine you're seeing the same kind of thing, but what are your thoughts?
Yeah, I would say, you know, I'm completely aligned on that. I see, you know, a future system where everything is integrated. You know, all these digital players that are coming in right now, they're all open API based and built to integrate with each other. So as we see Canadians embrace more and more of this technology and demand it from their system and from the providers, you know, we'll see privacy legislation and other things start to change to facilitate, you know, easier sharing of patient records from the hospital to the community, to the physicians in the community, and then also sharing of records with physicians online, right? We see an environment where you know, if you're talking to your family physician on Maple, if your family physician is not available, you can tap into our broader network of physicians and those records are seamlessly shared, you know, where we're efficiently using the capacity that's there while also equipping, you know, family physicians to be able to provide a broader scope of services to their patients, regardless of where they are. So I think, you know, I totally agree with all the points brought up. It's about integration. It's about patient-centric care, and interoperability is really, you know, our vision for the future. And we like to work with partners that, you know, all across the system that help us get the word out, help us, you know, get more adoption of the technology, and then, you know, help us to share records across different avenues of care.
Well, Chris, I like the vision that each of them has put forward. So let's figure out how to enable them to make it happen.
Absolutely.
Anything you want to add, Chris, from Health City's point of view on where this is going?
That's a tough group to follow. I can't add too much more there, but I think the key thing just to echo is accessibility. So even with, you know, existing partnerships that we have and with Maple and with Northwest, that's one demographic. They're international students that don't typically get access to virtual care. This allows them to, you know, to find services that they need if they're not even able to find a GP. So I think that is probably just going to be accelerated. And then I think there also is that culture shift that, you know, as all of you guys know on the call, it can be tough to get innovation into the healthcare system. I think now there's probably a new appreciation for why we need to do that. So I think that's really the hope from Health City is, taking a look at, what is part of that new health economy, as Reg always alludes to. How do we start to help, bring that into the system? And it's with partners like all of you guys on the phone. So appreciate it. And yeah, anywhere we can do to support those types of projects, we're happy to look at.
Okay, great. Well, thank you, everyone. This has been a really good conversation. I've learned a lot about virtual care, and I think we've touched on some pretty useful and important concepts to increase understanding of where this could all go and what it means for Canadians. So thank you to Christy at Maple, Sarah at Shoppers Drug Mart, Rohit at Brightsquid, and Chris at Edmonton Health City. Thanks again for this conversation. You can stay tuned for more talks from Health City. Check out edmontonhealthcity.ca, and you can follow each of these organizations online as well to see how they are impacting the future of healthcare here in Canada.
Great. Thanks, Mac. Thanks,
Thanks,
everybody.
everybody.